Welcome to our new section, Teach to Treat. This is where either Dr. Trisham or I will review some of the literature and give you a GP perspective on a given topic. And today we're going to be talking about some analgesic options for osteoarthritis treatment in our canines. So talking all about dogs today. This is because we have a bit of a special interest in this case. So Trisham and I have an Australian Shepherd called Charlie who has quite severe OA. And so this has been a bit of our research to educate ourselves and our clinic about what we should reach for as our dogs get worse. So osteoarthritis, we're going to do a bit of a refresher first, is a progressive incurable disease which results in chronic pain. This pain is maladaptive, meaning it doesn't have a purpose, and it's a terminal disease. So many of us know we euthanize a lot of dogs because of the pain they're experiencing in their joints. We want to diagnose early to reduce pain, improve mobility and quality of life of our pets. And most commonly, we see it in large breed dogs. So think our Labradors, Golden Retrievers, Rottweilers, German Shepherds. It's a bit more undervaluated in smaller dogs as they can compensate better on their smaller frames, and they're often carried by their owners. Our owners unfortunately attribute the clinical signs of this disease to simply getting old. So we don't often see it until it's advanced, when really pain in the dog doesn't need to be a normal aging process. It's something that we can manage well. It's a multifactorial progressive disease of those synovial joints and structures within it, especially the articular cartilage. We get subchondral bone, and also resulting in secondary damage to the meniscus and ligaments around them. Usually it's a result of inciting factors, so where we have joint trauma, for example, in our puppies, joint instability, congenital and developmental abnormalities, so hip and elbow dysplasia, for example, or obesity. And for this reason, we see it quite early in life. We think that about 20% of dogs over the age of 1 have a lesion of osteoarthritis. However, with more active screening of young dogs, it's probably more like 20 to 40% of dogs which have a lesion. As we said, it's a chronic pain and it's got a wider effect on our dogs' lives. So we can imagine if we were in chronic pain, our sleep would be affected. It affects our relationships. So think the dog that doesn't get along with the kids or the new puppy in the house. Obviously, our gait and our movement, because we're too painful to move, it's going to affect our life in a very broad way. So as we said, we have this initial inciting factor which creates tissue damage in the joint. An acute inflammatory process will persist, and this will progress to a low-grade chronic inflammatory state, and that will progress to the clinical OA that we see in the consult room. With osteoarthritis, we tend to think of two types of inflammation. There's our more typical inflammation within the joint. So we think of our macrophages, T lymphocytes, and mast cells, all releasing inflammatory mediators such as prostaglandins, which are going to cause damage in that joint. And thanks to Baranza, we now think about neurogenic inflammation. So our damaged synovial cells and chondrocytes of the articular cells are releasing nerve growth factor, which is going to bind to our peripheral nerves to stimulate a pain response. It's also going to bind to our mast cells to stimulate release of more inflammatory mediators. And that nerve growth factor has lots of other effects in the joint, such as angiogenesis and neuron spouting, which is all creating that diseased hypersensitive joint. We'll do a quick little refresher on our nociception, our pain pathways. For our purposes, all we really need to understand is that we have transduction in the periphery. So we have a conversion of that nociceptive stimulus into an electrical impulse. We're going to have transmission of that electrical impulse up to the CNS. There it's going to be modulated and finally perceived by the CNS in the brain. This is important because it means that we can control pain at multiple steps in that pathway. And more specifically to osteoarthritis, we think about pain wind-up. We have a chronic pain state. And with pain wind-up, we get this central and peripheral sensitization. We have an initial sustained peripheral stimuli, be it our inflammatory mediators or our nerve growth factor, a continued signaling of neurons to the dorsal horn of the spinal column, and then a perpetually excited neurons in the dorsal horn. So when we think about peripheral sensitization, we think of a constant presence of a noxious input in the periphery, and that will result in this reduction in threshold or magnitude of responsiveness to the noxious input, such as something like just touch could elicit a pain response. Our central sensitization means we have an increased responsiveness of the nociceptors in the central nervous system, meaning that, again, we are hypersensitive to stimuli. All of this means that we really do need a multimodal approach to OA. We want to address the pain at multiple steps along that pathway, and we want to address this sensitization. The goals of treatment for osteoarthritis are to reduce pain and inflammation in the joint, prevent or slow down degeneration of that cartilage, and to support or restore joint functions. As we said, we need that multimodal approach, and ideally we want to be getting onto this process early, which is why we don't want these owners perceiving it as a natural aging process. We want them in the clinic. As we said, multimodal approach, we're going to harp on about this. The main ones we're going to talk about today are our analgesia and our anti-inflammatories, our structure-modifying osteoarthritic drugs, which is essentially a fancy way to talk about our pentasans and our glucosamines, our oral supplements. But it's really important that you guys are talking about activity control. This is obviously quite hard sometimes. If we've got them on something like Baranza, they want to be running around. We need to be limiting this to a degree. Weight management, really important. We don't have extra weight on that joint. I think our activity and our weight management are two of the hardest things to control. Because, for example, I know my dog, he likes to eat. And when he can't run around the way he wants to, I want to be able to give him that little treat. It's hard to keep his weight under control. Nutritional support, be it Hills JD or another type of oral diet, physical therapy where our owners are interested in doing physiotherapy or acupuncture, surgical management certainly in dogs where they're a candidate or where the owners can afford it. So we all know hip replacements are a great option, but not all owners can go down this route. This is a list of a few of the drugs we're going to touch on today. Firstly, we'll talk about our non-steroidal anti-inflammatory drugs. This have been our first line analgesic for OA for years. And if we think back to our days at uni, we would have all heard about how they inhibit the cyclooxygenase enzyme, which is responsible for the production of prostaglandins in that arachidonic acid pathway. There are two COX enzymes. COX-1 creates many of our housekeeping prostaglandins. So they maintain GI and renal blood flow. They have gastroprotective mechanisms and are responsible for part of platelet aggregation. COX-2 are our inducible prostaglandins that are part of that inflammatory cascade. It's worth noting non-steroidals do provide analgesia via some central pathways also. So as we said, our NSAIDs were blocking those COX-1 and COX-2 enzymes. And for this, we were developing some renal and GI side effects, which is what we often think about with our non-steroidals. As we don't want to be blocking those housekeeping enzyme prostaglandins, which are having a key role in our body functions, which led to the development of our COX-2 specific non-steroidals. The ones we probably most commonly think of are our meloxicam, carprofen, and firocoxib, so Previcox. These are most widely studied, and there are lots of studies here to show that they have great effect. They reduce lameness, general stiffness, painful rise, improve our exercise tolerance, and overall an improved quality of life. They all have similar safety profiles, and interesting, many dogs can be sensitive to one and not another. So it gives us option for changing among the group there. It's worth noting that quite a few studies do mention that meloxicam is more effective than carprofen. So worth noting that in some of our older, more affected pets. NSAIDs are working to limit our peripheral sensitization as we're reducing the joint inflammation and reducing that sustained doxa stimuli, which is acting on those peripheral nerves. By limiting this peripheral sensitization, we're therefore limiting central sensitization. And so here we have a rationale for long-term daily non-steroidal administration. But what about side effects? We think of these very often with non-steroidals. Most commonly, we would think of our GI signs and our renal toxicity. And this is because our non-steroidals are blocking this PGE2, which is responsible for our blood flow to the kidneys and to the GI tract. Interestingly, most studies do report that renal and hepatic side effects are rare, and most commonly, the GI side effects we would see with long-term use. Interestingly, there was a webinar I listened to only a couple of weeks ago by Zoetis, by Dr. Fernando Martinez Taboada, and he actually mentioned that Australia does seem to have a little bit of a fear of GI side effects and renal side effects with non-steroidals, and that really there isn't a great basis for this, and there's a real clinical indication for their use. So we should not be afraid of these side effects. Do we see these side effects? Certainly, longer duration treatment will improve efficacy, and with longer duration, we worry even more that we'd see side effects. But many studies will notice that typically we don't see the side effects unless we have an underlying comorbidity, such as IBD or renal disease. Some studies, for example, which have looked into these non-steroidals, one by Molina, found that after 30 days of daily meloxicam, where we were monitoring renal, hepatic, coagulation, and hematological function through blood work, no signs were seen except for changes in gastric wall, which was another thing they were monitoring in that study, and that was seen after about 10 days. So there was a rationale here to use them together with a gastroprotectant. Another study found that most of these GI signs were actually transient and so were still appropriate for long-term use. And a further peer-reviewed lit review found that while many dogs did develop these gastric side effects, it was worth it for the significant clinical benefit that many of these dogs with OA were receiving. What should we do if we see these side effects? One is we can trial to reduce the dose. It's worth noting that dependent on the study, once we get to about 40 to 60% of our effective dose, we do start to see a loss of efficacy. So it may reduce side effects, but really we shouldn't be reducing this dose unless we're seeing them, unless we're seeing those side effects. We can trial swapping to another type of non-steroidal, so from meloxicam to Previcox, for example. Typically, we want a washout period of about 5 days between those drugs. Or obviously, we can swap to a different medication entirely, such as Baranza. How should we prescribe these medications? Ideally, we want to be running that blood work prior to starting, so we're ruling out that renal disease. Ideally, we want to give a course of at least 2 weeks to start, but many authors even suggest 30 days or more. And we want to be revisiting after 2 to 4 weeks to assess the effect of the drug and if we're seeing any side effects. If we're not seeing control at that point, we could add in a secondary medication. It's worth revisiting in 3 to 6 months. We want to be continually reassessing these pain plans and making sure the drug's effective and that our pain is under control. I thought it was worth discussing Trocoxil briefly. So our long-acting non-steroidals, and there are other types of long-actings, but we'll talk about Trocoxil specifically. I think some vets do have a fear of these drugs, which is understandable. If we put that drug in and the dog has a side effect, it's in the dog for a month. We can't take it out. There are a couple of good indications for this medication. One is obviously where we're having a compliance issue. So the dog that's difficult to tablet, or the owner who's a shift worker and isn't home at the same time every day. If this dog has been on that medication previously in a daily format, they're probably less likely to see drug side effects because they've tolerated that daily medication. And if we are really concerned, it's always an option to give them, say, a daily non-steroidal for a month. And if the dog copes well, we could then transition onto something like Trocoxil. Another great indication is for breakthrough pain. So where animals are too active or having a fall or that they've got puppies at home, we're having a higher level of that plasma concentration. So we're getting a higher level, hopefully trying to prevent that breakthrough pain. Or for those owners who are saying they do really well in the morning and then they're not so good in the afternoon as they get further from their dose. They're probably having some breakthrough pain as the plasma concentration of that drug is dropping. And so these dogs might do really well on a long-term medication that's having a higher level of that drug. We'll touch briefly on our Galliprant, which is our Piprant. And these are like a non-steroidal, but they're non-COX inhibiting. They work lower down in that pathway, such that we're blocking the one receptor, the EP4 receptor, as opposed to all of those prostaglandins. And so hopefully we'd have less side effect. We're finding that it's more effective in the treatment of mild to moderate OA pain. For severe pain, it's probably not quite as effective. The studies so far are still showing that non-steroidals are more effective. And so if we have a dog that can tolerate non-steroidals, they're probably going to be a better option than Galliprant. And our safety profile of Galliprant we're still waiting on a bit more of the literature to come through there. However, if we have a dog that doesn't tolerate non-steroidals well, and the owner is not interested in moving on to something else like a Baranza in injectable form, Galliprant could be a great option for these dogs. Next, we're going to talk about Baranza, so betenvetmab, which is a monoclonal antibody. So you'll remember earlier we discussed that damaged synovial and articular chondrocytes release nerve growth factor. It then binds to tropomyosin kinase A receptor on our peripheral nerves to create this peripheral sensitization. And we then get this stimulus into the dorsal horn to create central sensitization. Baranza is working by binding to this nerve growth factor so that it can't have this effect. Remember, there's a huge amount of nerve growth factor in our damaged OA joint driving pain. So this is where it's so effective. Where would we utilize this product? It's being marketed as a replacement for non-steroidals. We want to use it in dogs that are greater than 12 months of age because nerve growth factor, understandably, could have a role in growth and development. So we don't want to be blocking this in our young dogs. Our dose is 0.5 to 1 mg per kg, subcut at monthly intervals. I'm not going to go in depth about how we give this. You've probably heard about it all through the reps. But as we said, this monthly injection, subcut, ideally we want to commit to 2 to 3 injections before we start tinkering with that dose. Where we're not finding enough relief with that dog, we could consider increasing the dose to 1 mg per kg or giving it more frequently. Typically, it's going to be cheaper to increase that dose up as opposed to be giving it every 3 weeks. If we're still not seeing enough pain control at 1 mg per kg, we might need to add in another analgesic. It's we'd think this is quite safe for avoiding renal and hepatic elimination, as it's eliminated by endogenous proteases. So it's a good option for these dogs that have renal disease. Really important we combine this one with exercise restriction relevant to that level of OA, because our dogs might be feeling so good, they don't know they need to control that activity. We need to remind them. It's interesting to note that Baranza is not licensed as an anti-inflammatory, but it does have some anti-inflammatory properties. Again, we mentioned earlier, nerve growth factor does bind to mast cells to cause the release of those inflammatory mediators. And so by removing that nerve growth factor, we are removing some of the inflammation. The literature so far is saying that it's quite a safe drug. There's been quite a few studies ranging from 30 days to 9 months looking at our factors there, and found that no side effects were attributed to that medication, which is why our reps, when they come in, love this medication. We're saying it's technically side effect free. The most common side effect we would see is an injection site reaction. We see this with any injectable medication, so not something we specifically need to be worrying about. In humans, sometimes we do see a worsening in patients' OA when they're on their Baranza equivalent alone. I think we'd see this in our dogs where we're not having exercise restriction. So just emphasizing the importance of exercise management. Concurrent use of NSAIDs in people with our Baranza equivalent have found it a syndrome of a rapid progression of OA. We don't tend to see this syndrome of rapid progression of OA in canines, so we would hope that we would not see it when we're using the concurrent medication, because by itself we don't see that condition. We have had a study by Zoetis looking at a 2-week course of non-steroidals with Baranza that found no side effects, which is why it's licensed to be used for 2 weeks for things like breakthrough pain. What about side effects? I think it is going to be a bit of a watch this space. The studies that Zoetis originally put out were for periods of 3 months to 9 months, and some dogs we know are getting on this drug at a very young age. They might be on this medication for years. We're going to need to watch what happens here. We are hearing from overseas some reports of dogs that are developing neurological signs, PUPD, incontinence, and some do worry it's because we're blocking nerve growth factor in sites outside of the joint. Again, I think a bit of a watch this space. We're going to need to do more studies and see what's going on here. There is the potential for anti-drug antibodies, much like any monoclonal antibody. And so we might see some loss of efficacy with the drug in time. So we may need to increase the dose. This is just something we need to watch for in our patients. What if our patient's already on a non-steroidal? We need to start Baranza and then monitor for 1 to 2 weeks. If there's not enough pain control, we could consider adding another medication if we're not getting control. But after 1 to 2 weeks, if we see the dog's doing well, we would want to withdraw that non-steroidal. And we do that slowly over a period of 5 to 10 days. Remember, we can use the drug per licensing for 2 weeks together. So if we are getting breakthrough pain on just the Baranza, we can certainly use that non-steroidal for 2 weeks. Which one would we choose? It's really a discussion with the client over which medication suits their lifestyle more in terms of costing, whether they want to come into the clinic once a month. There's no reason to withhold Baranza for mild OA or mild pain. Remember, we want to get on top of this pain early in the disease, but certainly we need to make sure the owner can manage exercise restriction. We need to make sure the owner can manage coming in monthly to continue giving this medication. We're going to touch on paracetamol and codeine. Paracetamol is an analgesic, antipyretic, and it has no to weak anti-inflammatory activity. It works on central and peripheral pathways, and there are certainly many studies that show that this drug is very effective for OA pain. We do find that by itself, it's not enough. We would need to be combining it with something like a non-steroidal to effectively control our OA pain. We certainly do see hepatic side effects on high doses, and just a little reminder, no paracetamol to cats. I thought it was worth mentioning that paracetamol, there's a lot of information I listened from something called Zero Pain Philosophy, which is a really interesting website if you want to go have a look at that. They have some interesting podcasts as well. The specialist on there is an anesthesia and analgesia specialist, and he mentioned more specifically about the dose. And this same Zoetis specialist mentioned this too. The dose in the formularies for paracetamol is about 10 to 15 mg per kg. And this is off some studies done in the 80s and 90s where we used a human pediatric dose. And we actually find that dose of 10 to 15 mg per kg is safe, but it's not typically enough to provide effective analgesia. This author of that zero pain philosophy uses 33 milligrams per kilogram 3 times a day. The Zoetis specialist used 20 milligrams per kilogram because he found it was licensed in the world somewhere at 20 mg per kg, and so he felt that that was a good indication for that dose. It's worth noting that some studies do show that we don't see adverse effects until more like 100 milligrams per kilogram. How should we prescribe? Again, we want to check that liver function or blood work prior to prescribing, and ideally the dose we'd be looking at would be about 20 to 30 milligrams per kilogram. And it's worth noting that it is an every 8-hourly medication. Obviously, where hours have work and life and they can only give it morning and night, it's still better than nothing, but certainly 3 times a day is going to give better control. Depending on the author, some like this medication as a daily medication. There are others who prefer it as a breakthrough pain remedy. So where they've had a bad day running around with the puppy, for example, they get their paracetamol on that day. Codeine was quite interesting to me because I was under the impression that the pain relief for codeine was great. A lot of studies weren't quite supportive of this. In humans, its analgesia is provided by about 10% being metabolized to morphine. But in dogs, this number is a lot smaller. It's more like 1.5%. Studies in greyhounds have found that a negligible amount is converted to morphine. In other breeds, it is a higher percentage, but this still didn't translate to an improvement in lameness scores. It has also got a short half-life and quite a poor bioavailability. None of the studies that I reviewed mentioned and recommended this as an OA treatment. Paracetamol was definitely the superior choice. We'll touch on tramadol. It's a mu agonist, serotonin and noradrenaline inhibitor, and its effects are predominantly through its metabolites, which is why we find that some dogs don't get effective relief because not all dogs can create these metabolites. It is licensed for reduction of acute and chronic, mild, soft tissue and musculoskeletal pain. There are much mixed reviews in the studies out there, and certainly more studies and evidence is needed. One study found that dogs did not improve with it. Another found that while owners found that dogs improved, the veterinarians did not. And a third found that when tramadol was combined with a non-steroidal, they did better than the non-steroidal group. So really, as I said, it's mixed whether or not the dog's going to do well. The evidence is potentially not enough to be starting our dogs on this drug. How would we prescribe it though if we were to choose? It's definitely an adjunct for OA. It's not a primary medication we're going to be reaching for. It might be worth warning these owners that they may not see relief on that medication. Our dose is 4 to 10 mg per kg. It might take 1 to 2 weeks before we see full effect, and we can see a loss of efficacy over time. That same specialist at the zero pain philosophy certainly didn't prescribe it himself. However, if a dog came in and was doing well on that medication, or if they attempted to withdraw it and the dog did worse, he would certainly continue to recommend this medication. Next, we'll talk about gabapentin. Gabapentin binds to calcium receptors at our nerve synapse, and such by blocking that calcium transfer, we're decreasing the release of our excitatory neurotransmitter. So we're reducing that electrical transmission. For that reason, it's not going to be great for the acute inflammatory pain, but we're blocking that nerve transmission, which is certainly an important role. Literature has definitely found that when combined with things like non-steroidal, the drug is certainly very effective. Its indication is either going to be for our chronic neuropathic pain, so think disc herniations, plexus avulsions, nerve root impingements, or as part of complex pain requiring a multimodal approach, which we've certainly mentioned for OA. Our dose is 5 to 10 mg per kg. It's worth noting that it's an every 8-hourly medication. And I know in clinic, a lot of us prescribe it twice a day. So if a dog is not doing well, this could be the reason why. For BID dosing, it is worth considering pregabalin, which is a twice-a-day medication. The most common side effect we would see are sedation and ataxia, particularly at that high dose range. And certainly with a wobbly OA dog, we don't want to see an ataxic or a sedate dog compounding that. So certainly starting at the lower end of the dose range is safer. It is eliminated by the kidneys, so we should be using it cautiously in our animals with renal insufficiency. It's worth noting that dogs do have a larger component of hepatic clearance of the drug, so they will usually cope with this medication, but certainly a twice-a-day dosing is probably a safer option for these dogs. And cats, it is certainly something we should be very cautious with. How we prescribe gabapentin. As we said, it's not appropriate for a first-line analgesic for OA. We want to use it together with something like a non-steroidal or a Baranza as that multimodal approach. It's worth noting that in humans, when they use this drug for chronic pain, we do find that over time we see a loss of efficacy with the drug and that they do need to have their dose increase with time. So if we have a dog coming in after 12 months and they're no longer coping, they may need another drug added in, but they also may simply just need a dose increase of the gabapentin. It is also worth noting that it is absorbed by a receptor in the gut, and it does reach a point where it's overly saturated, and we can continue to increase the dose, but we will not see more effect. And for that reason, we just do need, again, keep a watch on these patients. We're going to reach a point where you can increase that dose and things won't improve. We'll talk next about our NMDA receptor antagonists, so amantadine, and ketamine. The NMDA receptors are located on both peripheral nerve fibers and within the dorsal horn of the spinal column. And so for this reason, we know they play a role in peripheral and central sensitization. Remember, our chronic OA has a big proportion of central sensitization. Amantadine is going to occupy this NMDA receptor, and so we're going to block this process, which is very favorable for our OA dogs. Amantadine, the literature certainly likes this drug, and we find that when it's combined with a non-steroidal, dogs do a lot better. They're better at performing everyday tasks, such as stair climbing, getting up from rest, walking on those slippery floors, and improvement in behaviours, such as aggression, vocalizing. It is a relatively affordable drug. Where cost is a factor, memantine is certainly an option, but the dose for memantine is not quite as well documented, so amantadine is the better option where we can grab it. How do we prescribe it? It's an adjunct. It's a secondary pain medication we're going to be adding in for our OA dogs. It's not a primary medication, and we really want to be considering this drug in any animal with central sensitization. Our dose is 3 to 5 mg per kg once a day. We might find it takes 2 to 3 weeks to see full effect, but we do find most dogs will eventually need to transition to twice-a-day dosing, and they will do better on twice-a-day dosing. Dogs do better on twice a day. We need to look beyond our lameness scores to monitor efficacy. A lot of these dogs will continue to be lame, but holistically they should be better. They should be happier. They should be vocalizing less. They might be eating better. Our dog is certainly an example of this. His lameness is the same, but he's so much happier to be around myself and our children and our other dog than he was before. It's excreted by the kidneys, so obviously check your blood work here. And the main side effect are going to be things like diarrhea and vomiting. It's usually transient. Again, something we found with our dog. After a couple of weeks, that side effect passed. We'll touch on ketamine. We don't have a great deal of published data, but we find we want to use this the same way that human medicine does. We want to decrease that central sensitization in chronic pain states. We can use this as either a CRI or a subcut injection, and that injection will be at varied frequencies, whether it's monthly, weekly, 3-monthly, depending on the dog. And it's worth noting we can use it together with amantadine. So just because you don't have a dog on amantadine, we can certainly use this drug too. One particular author liked to use a CRI at 5 to 10 micrograms per kg per minute, and this would be a period of about 4 to 24 hours. Our most common side effects were sedation, agitation, dysphoria. If it happened with these CRI cases, we'd either slow the transfusion or stop it for an hour while these signs resolved. Our subcut injections are 0.5 mg per kg subcut monthly, but certainly as that pain state is progressing, as it's getting worse, we can be giving it weekly in more palliative states. CBD oil we'll touch on next, and this has been gaining a lot of attention in recent years for our chronic pain states. It works centrally and peripherally, and we're certainly finding in some of our studies that dogs are getting improvements on this drug when used as a part of a multimodal approach to pain. We will need more studies certainly to continue to study this. The studies so far, there's a really good one by Gamble who looked at the dose and found that at 2 mg per kg, we got a really good analgesic effect. Both vets and owners were finding improvements here. A second study used that same dose as a transmucosal route and found that dogs did better, but once they were withdrawn from their existing medication, be it a non-steroidal, a gabapentin, the dogs did worse. So really just supporting that we need that multimodal approach to OA. How would we prescribe it? Again, not by itself, together with something else. Our dose is 2 mg per kg. Typically, you might need to get this compounded. So for local vets, for example, we used Berwick Springs. It is certainly quite an expensive one though, so owners do need to be dedicated to this medication. Corticosteroids, we're not going to touch on it much, but really, if you have that specific indication for steroids, go for it. We'll touch lastly on our candidate structure modifying OA drugs. So again, a fancy name for our things like pentasans, synovans, our glucosamines and green-lit muscles, all working to delay, stabilize, or repair OA lesions. Again, we're going to say it again, that multimodal approach to OA. One particular study compared dogs that had had their 4-weekly course of pentasan to a 4-weekly course of carprofen and reassessed them at the 8-week mark and found that the pentasan group were doing better. So certainly for mild OA pain, this is a great option. As that OA progresses to moderate severe pain, we're going to need to use it together with an analgesic, certainly, but really good support here that this drug is effective. It's worth noting that when we look at the licensing of this drug, it's 4 weekly injections up to 3 times a year. And I know many of our vets in Melbourne, particularly near us, do a monthly top-up of this drug. I don't have a problem with this. Anecdotally, we certainly find our old dogs do really well. But I think if you've got an owner that's declining treatment purely because they don't want to be coming into the clinic for a monthly injection, just remember, we really just need to commit to that 4 weekly injection course. That's what's going to give our dogs great benefit. Our orals, we've got glucosamines, chondroitin sulfate, for example. There's lots of studies on these two that show that we certainly get some good effect. We ideally need to commit to an extended period. One study, for example, showed 70 days was required before we saw benefit. And we do see those occasional GI signs, which are usually transient. So there's lots of studies on all of the different ones out there, and we all have varied results, but most show that we are seeing relief with them. So a really important part to help us with delaying that progression of our disease. This was just a little bit of a costing that I compared for these drugs. So for example, Joint Guard, which was our glucosamine chondroitin, which has good evidence, a 22 kilo dog on that 750 gram tub, and this was just a price taken off something like Pet Circle, roughly $200. We were getting about 300 days. That's really quite a cost affordable strategy for $200 for almost a year's medication. Other ones, example, Antonil, Foresight, a little bit more expensive, but again, that green-lit muscle still does a great job, and it's quite easier to administer, that liquid. So a great option for our pets. But there's so many on the market, it's really a bit of personal preference there. So bringing it all together, what happens when we bring these dogs into our consult room? There's a new scoring tool out there called the Canine Osteoarthritis Staging Tool, and it's helping us grade our dogs from mild to moderate to severe OA. We won't go in too much depth, but if you Google this particular staging tool online, it gives you extensive recommendations for each grade. So it is worth a look if it's something you're interested in. We've got an example of one here. The way that it works is we would first grade the dog. So we're looking at the dog's discomfort, their posture, their motion. We next grade the joint. We're looking at whichever joint is affected. We're going to use manipulation, movement, x-rays, all to give us a grade from mild, moderate to severe. It is worth noting, you can also look down the bottom here, we can see this preclinical indicator of 0 to 1. 1 would, for example, be something that's born a Labrador that has owners with hip dysplasia. We know they're a risk factor, so they might want to go on something like a Joint Guard from very early in life. Once we have some markers on here, the overall grade goes by the most severe indicator for OA. And this makes sense. Because if you have one joint with severe OA, it doesn't matter if the others are mild. We need to treat the pain in that severe joint. And this disease is progressive, so the other joints are all going to move in that direction. So for example, we're going to grade the dog. The 2 pictures down the bottom here, we can see both of those dogs are shifting their weight forward off their hips. They've got hip dysplasia. You guys all know how to do gait exams. You can see how dogs are moving in consult and get an degree of the pain and the effect there. When to grade the joint. Our veterinary assessment, an interesting way I found was through CREPIT. Crepitus, range of motion, effusion, pain, instability, thickening, combined with x-rays, owner assessment through things like canine brief pain scoring, all giving us an idea of how that joint is tracking. So for example, if we were doing my own dog here, Mr. Charlie, we find that Charlie has entered our consult room. His discomfort's at a moderate, his posture's at a moderate, and his motion is severely affected. Once we grade the joint, we'll just do the elbow, for example. He's got moderate pain on manipulation, moderate passive range of movement, and he's got severely abnormal x-rays. So we would call him a COAST stage 4. Why do we care that Charlie's a COAST stage 4, that he's severe osteoarthritic? We care because when these dogs present, if we have moderate OA or greater, we assume that a degree of central sensitization is present, and this needs to be addressed in our treatment plan. So even if you don't have time in consult to do a coast exam, we need to be acknowledging mentally to ourselves and to the owner if we have mild, moderate, or severe OA, because this is going to guide what treatment we choose. Creating a treatment plan. As we said, multimodal approach. We're going to assume that you've talked to the owner about weight management. You've started them on something like maybe Hills JD or a Royal Canin equivalent. We've talked about physiotherapy. We've restricted their exercise. You've put them on something like your Pentosan or Synovan, whatever you've got in their clinic. And we've discussed that these are lifetime commitments for these owners. This is an appropriate choice of medications. This is going off a few different pain specialists, many articles I've read. Many have suggested this very similar approach. We're going to prescribe 30 days of non-steroidals or Baranza. Then we're going to return, reassess the dog. Our second option is amantadine. Some specialists did use non-steroidals and Baranza together because they were comfortable with this, but it is off license. But our second choice, amantadine. Third choice for many authors was paracetamol, and whether that's a daily medication or, as we said, a bit of a rescue remedy, up to you, what you're comfortable in your hands. We want to consider adding in a drug from there. It's a bit of a pick your poison. So whether you're comfortable with gabapentin, tramadol, CBD oil, you can choose from there. Certainly, if you've got an indication for gabapentin earlier, go for it. But typically, Baranza are non-steroidal, next amantadine, and then to your third tier medications. Your ketamine subcut injection could really be added at any point in this pathway. If we think we've got central sensitization, that ketamine can be put in. A lot of authors also liked acupuncture as an option for a holistic add-on. When we monitor this drug, we want to assess each new drug after 2 to 4 weeks of use. Ideally, we would use things like pain scoring, such as a canine brief pain inventory, our physical exam, our owner assessment. We might repeat that coast exam. It's worth noting that in many of these pain studies, lameness did not improve. Many dogs that were on medications did not improve their lameness, but holistically, we have happier dogs. They're able to get up the stairs easier. They're vocalizing less. They're playing with other dogs in the house. So set those client expectations. Just because the lameness doesn't improve, the dog may still be doing better. Our brief pain inventory, I thought this was a really interesting one to use. I think it would be quite easy to use in clinical practice. Take a photocopy, pop it in your consult room. When the owner's filled it in, snap a photo, pop it on the file. It's a good way to prove to ourselves and the owner if the dog has in fact done better on that medication. Well, I thought we'd finish with a little case example. This is Larry, the fat lab. He's our 10-year-old, overweight, arthritic Labrador, and he comes into the consult for an OA check. He's not come in before. We've used our coast exam, and for example, we found this dog has mild OA. We're going to start on non-steroidals or Baranza, depending on what that owner's comfortable with. We'll reassess in 4 weeks, and we can go from there. Add more medications if needed. Keep going with just the Baranza if everything's under control. We're assuming, as we said, you've got the dog on Pentosan. If you have this same dog comes in and you assess it to have moderate to severe OA, we assume that central sensitization is present. So we have a rationale here that you could immediately start on a second tier pain relief. This dog could be a candidate for Baranza with amantadine straight away. If the owner's not prepared to start on multiple medications, certainly start on a non-steroidal or Baranza, revisit in a month's time. And if the dog's not doing well, then the owner may be more receptive then to adding in amantadine. If the owner's not prepared to do amantadine straight up, we could start with that ketamine injection. Address that sensitization. Don't be afraid to get in there. So really ask yourself when a dog presents, is there central sensitization present? If there is, we have rationale for more than one drug. So I think set those client expectations. Don't be afraid to use more than one medication when necessary. I thought I'd finish on a little picture of our dog here. This is Charlie. He's been doing a lot better lately with a few of the drugs we've added in. I hope that the tips and tricks that we've reviewed today can really help you in your clinical practice. I've certainly learned a lot in reviewing it. So keep an eye out for Teach to Treat. We're hoping to have something up every 2 or 3 months. Keep an eye out for the next one. Thanks for your time.